So welcome and thank you for coming to the New Canaan Library tonight. We're deeply appreciative of Stanford Hospital and New Canaan Chamber of Commerce for co-sponsoring these important med ed lectures with the library. And I hope people won't be too upset, but we have a problem with people being chronically late in this community, so people will be wandering in, as I'm sure you've observed before. Tonight is the second in our 5-week series, and we welcome Drs. Corinne Van Beek and Daniel Zelazny. We are especially delighted to welcome back our physician moderator, Dr. Dina Ebright, who practices here in New Canaan at Fairfield Primary Care. Dr. Ebright?
Thank you. Good evening, everyone, and welcome to our second lecture of the Med Ed series. We're having an orthopedic lecture tonight. As Jocelyn mentioned, this is a collaboration between the hospital, the library, and the New Canaan Chamber of Commerce, and I want to give a special shout out to our folks from Physician Relations and Jocelyn for helping us organize. My name is Dina Ebright. I'm a general internist here in town. My office is on Grove Street. And tonight we have two speakers. I'm going to introduce them both. Our first speaker is Dr. Corinne Van Beek, who will be speaking today about the shoulder. And our other speaker is Dr. Daniel Zelazny, who will be speaking about the knee. Dr. Van Beek trained in orthopedic surgery at Columbia University Medical Center, and then she pursued further fellowship training at Thomas Jefferson University in the shoulder and elbow surgery. Dr. Van Beek enjoys working with athletes of all ages and sports, and she equally dedicates herself to the aging population, treating degenerative conditions of the shoulder and elbow. She practices in one of our SHIP practices at Premier Medical Group in Stamford. And Dr. Daniel Zelazny trained in orthopedic surgery at New York Medical College. He then pursued fellowship training in orthopedic trauma at Westchester Medical Center, and in sports medicine at the Graduate Sports Medicine and Human Performance Center in Philadelphia. He's the team physician for the Stanford High School and Westlake High School in Westchester, New York, and Dr. Zelazny practices at University Orthopedics in Westchester, New York, and also sees patients in Stanford at the Premier Medical Group site. So without further ado, Dr. Van Beek.
Hi guys, good evening. Thank you for being here. I know it's beautiful outside, so I'm impressed that you guys want to hear me talk instead of sunbathing outside, so thanks for coming. As Dina mentioned, we are at Premier Medical Group. Premier is part of the Orthopedic and Spine Institute, which is down in Chelsea Piers of Stanford. A lot of people know Chelsea Piers, so as you go down the hill, we're on the right-hand side, right above the daycare, so it's great during the day. So today I'm going to be talking really just about the shoulder. I could talk days and days about shoulder pathology. So we're going to try and do a brief overview, but more general, and then go into a little bit more of the complex pathology because this is the mini med school project. So we're going to talk a little bit more into some of the details regarding the shoulder. So we're going to understand or try and understand the normal shoulder anatomy. We're going to understand what happens when things go wrong. So the shoulder pathology, understand what our treatment options are. We're going to go into some of the basics. And then we're going to go into some of the complexities discussing arthroscopic surgery. Arthroscopic surgery is when we go in with the camera and small instruments and fix things. And of course, I have this great desire and enthusiasm for the shoulder, so hopefully you'll leave less intimidated by the joint that's probably bothering you. So when things go wrong, I'm going to talk about the rotator cuff. That includes bursitis, as well as things like rotator cuff tears. We're going to talk about the labrum. We're going to talk about the AC joint or the acromioclavicular joint, this top joint, and then what happens when you develop arthritis. So the shoulder is composed of three main bones. So the first bone is the arm bone, also called the humerus. Then we have the wing bone, also called the scapula, and then the clavicle or the collarbone, which is very superficial. So if you look at an x-ray, this is an x-ray of a shoulder, it's the ball and socket joint. So the ball is exactly that that's labeled, and the socket is the other part. So there's one main joint, and then we have two smaller joints around the shoulder. We have the top joint, the AC joint. Then if you follow the collarbone all the way into the inside, we have the SC joint, or where the sternum attaches to that collarbone. Then to get more specific, really it's not that complex, promise. We have two other false joints. We have the subacromial space and the scapulothoracic space, which I'll discuss in a little bit and discuss why they're important to acknowledge. So surrounding that ball and socket joint is the rotator cuff. So usually everyone in the room has at least heard of that term, very daunting, or at least knows of someone who's had rotator cuff repair surgery. So the rotator cuff is actually four muscles. They coalesce and combine to form what's termed the rotator cuff. So there's a front muscle, which is what's labeled as the subscapularis. Then there's the top muscle, which is called the supraspinatus. And then two back muscles called the infraspinatus and then the teres minor. Now, if you remove the ball from the socket, we have the labrum. This labrum is this structure that I'm pointing to. It's like the meniscus of the knee, okay? So the labrum is 360 degrees around that socket. Then, as I was discussing before, we have the top joint right here, which is the AC joints. And then when I refer to shoulder bursitis, I'm talking about a sac of fluid. That sac is this sac right here. This sac sits above the rotator cuff and below the bone. So that's when we talk about bursitis, this is what I'm referring to, this sac. Then we also have the powerhouse deltoid muscle, which is, so all those muscles, the rotator cuff muscles, they're deep inside. You can't palpate them. The deltoid is the powerhouse muscle on the outside. Then we have the trapezius muscle, which again is a more superficial muscle. And those also help move our shoulder. So, of course, talking about the anatomy, you have to talk about the scary stuff as well, which includes the nerves and the blood vessels that innervate our muscles and help bring nutrition to our muscles and make them work. So talking about the biomechanics, that was a brief overview of the anatomy, talking about the biomechanics. So how do we move the shoulder? How do our muscles and our bones work together to elevate our arm? So the first most important thing is we need smooth joint surfaces, we need an intact rotator cuff, and we need an intact deltoid. So it's golf season. So everything in my life right now, even though my golf game isn't that great, is relating to golf. So let's think of the ball and the socket joints as the ball or the humeral head as the ball on a golf tee, and think of the socket as the golf tee. So in order to keep that ball inside the socket or to keep that ball on the golf tee, you need, I said, a smooth joint surface, right? So if you chipped off part of that tee, because you're a bad golfer, for instance, if you have a ridgy tee, there's no way that ball is going to stay on that socket. So when you don't have a smooth surface or a smooth tee, that happens in the setting of arthritis. So this is what arthritis looks like. This is an x-ray. Here you have a bone spur, right in the bottom here. You have loss of joint space, so no longer can that ball glide smoothly on that socket. So now you also need the rotator cuff. So the rotator cuff is actually this man sitting at the bottom here. The rotator cuff keeps that ball centered on that socket, so when you elevate the arm, your deltoid can work. So this is your deltoid. So imagine you don't have the rotator cuff or this man anchoring down that ladder. If you don't have him anchoring down that ladder, that deltoid is now going to try and elevate the arm and is going to cause, it's not going to keep it centered on the ball, not centered on the socket rather, right? Does everyone get that? Okay. So that's why the rotator cuff is super important. So when you don't have an intact rotator cuff, well, like for instance what? So if you have what's called tendinitis or bursitis or impingement syndrome, or if you have a torn tendon, so a small tear, a medium tear, a massive tear, that can prevent that ball from being kept centered on that socket, and it's going to be hard to lift your arm up. So what does rotator cuff tendinitis or rotator cuff tear look like? These are images from at the time of surgery. So this is one of our top tendons here, and there's a lot of fraying. This fraying is what tendinitis looks like. When you have a tear, there's a hole in the tendon. Here's the tear on the bottom. So usually the spectrum, it can be on a spectrum, right? So there could just be inflammation or there could be tears, And usually that correlates with age. Not always, but frequently. So the younger you are, usually younger than 40, less likely to have a full tendon tear. As you get older, and our tendons are as old as we are. So if you're 65, your tendons are 65 and have been through your entire life. So they get thinner and thinner and thinner and more predisposed to tearing. So how do patients with rotator cuff problems present? Remember, they can't lift. The ball isn't centered on the socket. They have a hard time lifting up the arm. So usually they present with arm pain, weakness. They usually have the pain in like a band-like distribution. Hopefully you're not one of those. They have a lot of nighttime pain, so difficulty sleeping at night. Sometimes they have some stiffness because they can't move the arm around as much. So on physical examination, again, going with the mini med school, we're going into some of the complexities now. So on physical exam, what is your physician looking at? We usually have you disrobe, or women wear gowns, so we can fully inspect the shoulders. And so we look for atrophy. Atrophy is when you no longer have those big bulky muscles. So this is what atrophy looks like. You see how you can see the bony anatomy? That's not normal. You should have nice, firm muscles that overlie that bony anatomy so it's not as visible. Biceps deformity, sometimes people will come in with what we call Popeye deformity, the big bulky biceps, and that's because they ruptured that tendon. Then we use palpation. We track along certain bones and we see if you're tender there. This is the AC joint, the top joint. We check out your range of motion. We could do that standing as well as when you're flat. And we check multiple planes, so up and to the side, because your rotator cuff is responsible for rotation as well as elevation. We check behind the back. And then we look at rotator cuff, how strong your rotator cuff is. So one of my patients actually came in, I was very impressed. Apparently he did a Google search and he said, well, I have pain when I do this one, but I don't have pain when I do this one. So clearly, he either came to one of these similar seminars or something. But so essentially, with each different motion, we're checking a different tendon, right? So we said there are 4 rotator cuff muscles. So each thing that we do in the office is checking the strength of one of those 4 tendons. So the subscapularis is that front tendon, and we often refer to that as a very, very important tendon, probably one of the most important out of the 4, as frequently when it's torn, patients don't do as well with non-operative treatment. So findings that are consistent with rotator cuff pathology, usually they're over the age of 40. They have that band-like arm pain and pain with elevation over the head. They have pain at night, usually some weakness. Sometimes some of that wasting that we talked about on physical examination. They have loss of motion. They're younger than 30, less likely to be a rotator cuff problem. If they have numbness or tingling, that's usually from the neck or sometimes from the elbow nerve. If they have pain going from the neck all the way down to the fingers, also more likely to be from the neck. So frequently we'll obtain x-rays in the office, and everyone says, well, I know it's not broken, so I don't need x-rays. However, x-rays tell us a lot more than whether or not your bone is broken. There are subtle findings that we as the physician look at to tell us whether or not your tendon is torn or if you have other things going on that could be accounting for your symptoms. So for instance, this is what we call sclerosis, or sort of whitening of the bone that indicates that 2 bones are rubbing against each other. And down here, there's a calcium deposit. That implies that there's calcific tendinitis, and probably not a rotator cuff tear, but it's when there's bone in your tendon. So this is another, for instance, here, where there's a big calcium, or I call it a rock in the office, so a rock in your tendon that's causing your pain. So another subtle finding I'll look for as well is when there's elevation of the ball in the socket. Usually that tells me, going back to that golf ball and the tee analogy, that there's insufficiency of the rotator cuff. I'll look at the acromion. So this is where your genetics, you can thank your mom and dad, sometimes plays a role. So our acromion is our big wing bone, comes out over to this bone that's very palpable here. So we look, it can either be flat, it could be curved, or it can be hooked. And this is not something that you did to get a hooked acromion, it's just something how your body developed. And so if you have a hooked acromion, that hook is causing, it's impinging or touching on that rotator cuff that sits right below it. That, of course, is going to cause a lot of pain. Sometimes we'll get an MRI. An MRI is great to look at our rotator cuff. MRIs show us the soft tissues, right? X-rays show us the bones. MRIs show us the soft tissues. So MRI is excellent at looking at rotator cuff tears and predicting the size of the tear. Important for us to note is that over 50% of patients over the age of 60 have at least a partial tear of their tendon and have 0 symptoms. What's more impressive is that next line. So 30% of patients between the age of 60 to 70 have a complete tear through their tendon and have 0 symptoms. So that's pretty important. As we get older, that percentage increases as well. So what do we do if we diagnose you with a rotator cuff problem? So usually we say, okay, wait a couple days, see if your symptoms completely resolve. If not, come in for an evaluation with your physician. You want to avoid putting I know it's natural tendency when you have pain, put it in a sling to rest it. We say don't do that for more than a couple of days because then you could develop something called frozen shoulder or a very stiff shoulder. That's something you absolutely want to avoid, so don't put your arm in a sling. We usually recommend anti-inflammatory medications, ibuprofen, naproxen, Aleve, Advil, to decrease the inflammation and decrease the pain. We'll usually send someone to physical therapy. How does physical therapy work in the setting of a rotator cuff tear? It works once your tendon is torn off the bone, there is no way for it to heal back down to the bone without surgery. However, that doesn't mean that we operate on everybody with a rotator cuff tear. We'd be in great business if we did. So what we do in physical therapy is we strengthen the other tendons that are still intact to compensate for the one that's torn. Sometimes we'll do an injection or a cortisone injection, and that purpose is to, again, decrease the inflammation and decrease the pain. Does not affect the healing, sometimes can actually inhibit the healing of the rotator cuff, so we got to be careful with those injections. And then occasionally surgery is needed. So what surgery is, so there are a lot of controversies in rotator cuff repair surgery. It can either be a big open surgery, which we infrequently do now. There's been a paradigm shift, and we're going from less open surgeries where we make big incisions more to arthroscopic surgery, where we make little small 1 centimeter incisions around the shoulder to fix the tendon. We can fix it what's called single row, double row. We can treat different tendon tears different ways. So when it comes down to it, it depends on the surgeon. So factors that influence our decision to operate on a rotator cuff tear is if a tendon is torn acutely, meaning if that happened a couple days ago, we're more likely to try and fix it immediately because we have a better repairability of that tendon. If you're younger, we're more likely to fix it. If you're more active, and again, if that front tendon is torn, we're more likely to fix that as well. So the big open incision, this is what I was talking about. That used to be back in even like the 1980s. So when Dr. Zelazny was, practicing. I wasn't born yet. Then we have the mini open approach. Mini open approach is a much smaller incision. And then there's the all arthroscopic, when we go in with those small incisions and bring that tendon back down to bone. That affords a 360-degree view, so a much better viewing. So the goal of the surgery is to bring the torn tendon, which is back here, back down to the bone. So the arthroscopic, that's my preferred approach, is when we make those small incisions. We use small instruments and a camera. So here's the camera that we use. We visualize the entire shoulder joints. We use these cannulas or things that we could put our instruments through these little cannulas to fix the tendon. We'll sit you into various positions. So this is the beach chair position. So we actually sit you upright. That's my preferred approach. Usually the East Coasters prefer to keep you in the beach chair position. Usually on the West Coast, they prefer you to lie you on your side and then fix you that way. Again, not a huge difference. There are some studies to discuss, obviously, the risks and benefits of both approaches. And then these are the various incisions, or also called portals, that we can use depending on what your pathology is. So we'll use various instruments and anchors. Anchors are little plastic pieces, which you could see here. This is an anchor. This is what gets inserted in your bone and has these strings or sutures attached to it. Those sutures are what get passed through your tendon. So this is what a repair looks like. So we put that little plastic piece inside the bone, we pass the special string or suture through the tendon, and ultimately this is what the repair looks like. So afterwards, usually there's some duration of immobilization in a sling, usually about 4 weeks, 4 to 6 weeks. We begin physical therapy soon thereafter, and at about 6 months, you're 85% better, and it usually takes a full year before you're about 95 to 100% back. So, yeah. Sorry to break the bad news, buddy. So as I discussed, one of our greatest advancements is arthroscopy. Well, in the next generation, we're trying to figure out, okay, so now we have, for the most part, the repair strategy down and good and solid. Now, how can we enhance the healing process? So that's where a lot of our investigations have really focused on now. A lot of people have heard of platelet-rich plasma. Heinz Ward was sort of the one that kind of introduced it more to the world after he won the Super Bowl. But a lot of people are familiar with it because we can do it in the office. It's when we spin down some of your own blood and inject it into the area of the tendinitis or the tendon tear to enhance the healing. There's also something called a patch, a rotator cuff patch, which is what you could see in the second picture here. We put that actually on top of the rotator cuff, and the thought is that we'll get a more robust repair. And then, of course, there's all this stem cell talk now returning to orthopedics about possibly removing some of your own stem cells locally or from other locations, such as the hip, and putting it at the repair site to enhance the healing there. So, if you're not bored and your attention span is as short as mine, hopefully I haven't lost you yet, we're going to move on now from the rotator cuff to the labrum. So again, if you remove the ball from the socket, the labrum is that structure that completely surrounds the socket. So the most common type of labral tear that people are familiar with, something called a slap tear. And a slap tear just refers to a tear specifically in this upper location of the labrum. Frequently you'll hear some of your favorite athletes have slap tears. It can occur with any type of traction injury, occasionally with compression, repetitive activities such as pitchers frequently get it. Jet skiing, summertime sports, you can occasionally get it, or something, if there's a deceleration injury, you can also sustain that type of injury. Unfortunately, the diagnosis can be very difficult and challenging. It can mimic other diagnoses, and it is frequently associated with other problems as well. But if your mechanism, what we just talked about, is consistent with a labral tear and you have similar findings for it, then frequently it's a labral tear. Now, how can we confirm it? We can get an MR arthrogram. It's an MRI, and then we inject dye inside the shoulder joint so we can better visualize the labral tear. So this is an MR arthrogram where there's dye inside the joint here. Remember, ball, socket. Here's the ball. Here's the socket. Here's the labrum. So here the dye is going underneath the labrum, and that's consistent with a tear. Again, here the dye is underneath the labrum. The labrum is this structure, so the dye is underneath the labrum, again consistent with a tear. Occasionally the tears can be associated with cysts, and those cysts can compress your nerves, so it can get pretty extreme, the pathology. So everything in orthopedics is graded, so we grade these. Type 1 slap is just when we have some fraying, versus a type 2 slap is when there's complete dissociation of the labrum away from the bone. That's what it looks like on an MRI. Type 3 is when you actually have a bucket handle, when part of the labrum actually flips down into the joints. And then type 4 is when your biceps, right here, becomes involved as well. So we can try physical therapy and conservative management, and occasionally, again, surgery may be necessary. So depending on what type of tear that you have, we'll proceed with it in different respects. Sometimes just a little cleanup of the labrum versus a more aggressive repair. The repair, again, is using those plastic anchors. And so we'll insert the anchors right at the socket, right here. And then we'll tie the string or the suture around the labrum and bring it back down to the bone using these instruments, also called suture hooks. So now we're moving more toward knotless approaches, and the thought here, so here's a suture with a knot. The thought now with doing knotless approaches is that now we do not have a knot rubbing against the cartilage. We're still investigating as to whether or not this is truly advantageous. I personally do the knotless. I know other people who do knots, who throw knots, and there's no problem. So just a thought for future. So post-operatively, how do we treat you? You're usually in a sling for a period of time and then physical therapy, so similar to a rotator cuff repair. I'm briefly going to just mention a separated shoulder. I know we have some younger guys here, so frequently people will say, oh, you know, my shoulder dislocated. Actually, what you're referring to is your AC joint and the bones separated from each other. So again, we grade them, the types of tears based on what ligaments are torn. So again, we have 6 different types, and usually you present with tenderness right at the top joint here. Sometimes you can see that the collarbone is elevated. Occasionally I'll have some bruising there, and then pain with any type of motions like across the body or behind the back. So frequently, if it's just a minor sprain or you just tear some of the ligaments instead of all of them, we could put you in a sling. If you tear through a lot of them, sometimes we'll have to do more aggressive approaches such as surgery. And we make an incision and actually use fake tendon, also called allograft, and weave it through bone here to bring the clavicle or that collarbone back down. So now I just said, arthroscopic approaches now are becoming, it's one of our greatest advances. So now we're actually treating this arthroscopically as well. This is the guy I treated who had an AC separation here, as you can see on this bottom image as well. And we fixed him arthroscopically and placed a button. Instead of using the fake graft, we placed the button here and brought the collarbone back down. So now if you look at the AC joints, his is level again. So pretty nifty. It was fun. So now we're going to switch gears just quickly from the younger athlete, the rotator cuff repair, labrum tears, and AC joint injuries, now to the older athletes. What do we have to look at in the future if we're an aggressive athlete at a younger age? And that is arthritis. So arthritis is when we lose the cartilage. If you look at the end of a chicken bone and it's a nice, smooth, shiny surface, that's cartilage. So arthritis is when we lose that cartilage or that smooth surface and we go back down, all the way down to bone. So now there's no longer cartilage there. So this is what arthritis looks like on an x-ray. There's loss of the space between the ball and the socket, and now there's a lot of bone developing on the bottom here. So what do we do about arthritis? Unfortunately, we haven't learned yet how to reverse arthritis. Hopefully we will in the future. But we can try and prevent it from worsening. And in the shoulder joint, that means avoiding aggressive overhead lifting and limiting overall repetitive activities, especially overhead. We can try anti-inflammatory medications to decrease the pain. And there's something called viscosupplementation. Now, viscosupplementation is almost like WD-40 for doors. It's like a lubricant. So that's what we can inject inside the shoulder joint. It's almost like a gel to recreate or allow for better gliding of the ball in the socket. So besides the injections, we can do steroid injections as well to decrease the pain. We can try physical therapy to enhance and improve the motion. And then eventually, a total shoulder replacement may be needed, and that's when we remove the arthritic parts of the bone, and we put in a metal ball and a plastic socket. And the plastic socket is what you see on the bottom picture, and that recreates that nice, smooth gliding surface and decreases the pain. Sometimes you can have, if you have a rotator cuff tear that's very large and that has been untreated, then you can develop arthritis because of that rotator cuff problem, and that's a special type of arthritis. It's called cuff tear arthropathy. When you have that, you can't put in the standard ball and socket, but you put in a reverse ball and socket, where now instead of the ball being on the typical ball side, we put the ball on the socket side. And now the deltoid is what's responsible for powering that implant and moving your arm up and down. So we discuss a lot. So we discussed normal anatomy, we discussed some of the pathologies that you can expect, we discussed arthroscopic treatment a little bit. When you can proceed with non-operative management, what does that mean? And then if you need surgery, what that means. So hopefully you won't need surgery, but if you do, you can call and make an appointment at the office. I'd be happy to see any of you. Anybody have questions right now, or you want to hold off on questions until after?
We'll keep the questions at the end.
Perfect.
We'll do it now? All right, we can do questions
Do it now?
Yeah.
Yeah.
Is viscose supplementation available for ankles?
It actually is. So the FDA has only approved viscose supplementation for certain joints. The knee is the primary joint that's been approved. We actually do inject viscose supplementation in other joints, but you have to know that it has not been FDA approved yet. For instance, for the shoulder, the FDA just approved it recently, a couple months ago. Medicare just started recognizing that. So I don't think it's FDA approved yet, but it is available for a possible.
So without FDA approval for an ankle joint, then there would be no insurance covered on it, correct?
Yes.
The part where you have the patient sitting up and doing the shoulder surgery.
Yeah.
Is the patient anesthetized?
Great question. So you're sedated, meaning that you are not aware of what's going on. You're in a deep, deep sleep. Sometimes, well, we'll always give you supplemental oxygen, and very infrequently will you actually need a full tube down the throat. So you're completely sedated, not familiar with what's going on, in a deep sleep, and then it makes your recovery much easier, right? So you don't have the sore throat afterwards, but yes, you're not familiar with what's going on. Yeah.
You were talking about overhead activities. What did you mean?
Overhead activities meaning anything above shoulder level. So like this would be an overhead activity. So if you're, for instance, lifting weights in the gym and you're doing overhead activities, overhead lifting like this, that's super bad for the shoulder. Shoulder doesn't like that. It's not used to that amount of force across the joint.
Or
Getting something from like a high cabinet, but if you're repetitively doing that, it's going to cause pain. Yeah.
Yeah. Does it really take that long, from 4 to 6 months to a year to heal?
Yeah, absolutely. Because you need adequate blood supply to go to the rotator cuff and actually put down all the important healing factors, and then your tendon will heal back down the bone.
Because I had orthopedic, like you were saying, orthopedic with pins, and they got the, we drew a picture on my,
Mhm.
my arm.
Takes a long time to recover.
Yeah, I didn't realize it was that long, but I'm trying to get back to work, and they said, don't rush it.
Don't rush it. You need your body to heal it.
I said, I'm
Slow, gradual process.
getting tired of doing nothing now, the pain in the neck is, but anyway.
It's frustrating. Yes.
A number of the surgical procedures you showed had various sutures or ties or patches. Are those permanent or do those dissolve?
Depends on what we use.
Mhm.
Depends on, there are specific types. There are a lot of different types that we can use, but some are degradable, some aren't. Yes.
Yeah, just a question on the physical therapy for rotator cuff tear. You talked about 4 muscles,
Mhm.
but then I think when you were talking about the therapy, you said it was strengthening tendons. So
Yeah,
is that
great.
therapy strengthening
So what's
the
muscle or what's
tendons,
tendon?
or am I just confused
Great
about
question.
that?
No, I should have clarified. So a tendon, your rotator cuff is muscle and tendon. So a muscle converges and becomes a tendon before it attaches down to bone. Okay? So when we say a muscle or a tendon, we're almost using them interchangeably because that muscle becomes a tendon before it goes down to its attachment site onto a bone.
Okay.
We don't strengthen tendon really, we strengthen the muscle part of it. Okay? Anything else? Okay.
All right, thanks everyone. I apologize for missing the very beginning of this, but that's what happens when you have 3 kids under 6 at home and your wife yells at you for leaving again. So you wind up being late for almost everything except surgery and the office. Those are things that those are hallowed ground. So my name is Dan Zelazny. My charge is to talk about the common knee issues that a lot of people face and deal with. I'm sure you've known someone. If you haven't had it yourself, you know someone who's had a knee injury. I know that because I'm not only the president of the club, but I'm a victim as well. So I work at Stanford Hospital Tully Center. I also work at Westchester Medical Center and Phelps Memorial Hospital in Westchester. My mother made sure I had to say that I was Top Docs magazine this year in Westchester, and I also the team doc for Marist, Vassar, and Stanford High for many years. I'm a kind of native Stanfordite. So I'm going to test you a little bit with history first before we go into some medicine. Anybody know who Elizabeth Clausen was? Okay, so in 1692, what happened in the United States that was pretty popular, very famous? Salem, Massachusetts, right? The Salem witch hunt. So Stamford, Connecticut actually has its own history with the witch hunt, and it had, it wasn't to the degree of Salem, but Elizabeth Clausen was one of about a half a dozen women who in Stamford were accused of being a witch. And there was a kind of a big to-do about it, as you can imagine, and they had to kind of figure out through a trial process of whether she was actually a witch or not. Now, I'm sure you may not know the answer to this. So how does anyone figure out if someone's a witch? So there were a few tests at the time. So they're similar to the medical tests that we do today. So one of them was like if you had a sword and held it over the witch, they would start laughing uncontrollably. So they actually did that to Elizabeth Clausen, and she started laughing. So, but they said, well, let's do it again. Maybe it's not really true, and she didn't laugh the second time. So then they did the other test, which was supposedly if you took the supposed witch, bound their hands and feet, and threw them into a body of water, they would float. And if you were innocent, which is rather unfortunate, you would drown. So, but interestingly enough, she supposedly floated. And they still were not convinced. And ultimately, she was acquitted, along with the other half a dozen or so, because the woman who accused her was like from a competitive family that they were arguing back and forth, so that was kind of the motivation to say that she was a witch. So they finally let her go. And there was actually a good book about this whole thing. It was called Escaping Salem, and it talks about the Stamford witch trials. There you go, so you learned something. Quiz at the end. All right, I have no financial disclosures. We're supposed to say that, but Stamford Hospital is going to take me to Capitol Grill, but they don't know it yet. Okay. So let's talk about some knee issues. So one of the most common reasons that people present to a doctor in all of medicine is because they have knee pain. Not necessarily to the orthopedic person, but even to their primary care physician, family physician, whatever you would call. That's one of the most common reasons that people go to the doctor. And this is according to this, ABOS is the American Board of Orthopedic Surgery. They collect all this data and try to figure out. As a matter of fact, one of the most, these are like the David Letterman's top 10 surgeries, and knee arthroscopy for meniscus tear is like the most common surgical procedure performed in the United States. Carpal tunnel, taking out hardware, knee arthroscopy for arthritis type issues, shoulder arthroscopy, knee replacement, knee arthroscopy for ACL reconstruction, hip fractures and hip replacements. Those are like the top surgeries, certainly orthopedic. And these are becoming much more common, certainly for many, many reasons, but a lot of it has to do with the aging phenomenon and the increase in our life expectancy. So if you were in 1900, the average life expectancy was 47. In 1988, it was up to 75, and now in the year 2000, it's even a few years above that. And why do we have this increased life expectancy? Sure, because of medical advances, absolutely true, but also because the patients themselves are much more active and motivated and health conscious than they ever were, and they wish to remain that way for many years. So as Ben Franklin would say, people want to live long, but they don't want to live old. There's a lot of benefits to doing exercise as you get older and be active. There's obviously the cardiac, the heart benefits, the lung benefits, and the musculoskeletal, the orthopedic benefits. It improves balance, it improves your coordination, decreases your fall rate. People fall down if they get weak and deconditioned, break your hip, all those things that you also probably know. Not to mention only even the social benefits, just being out, being around with other people and being active. As a matter of fact, also, in 2005, the New York City Marathon, the average age of the participant was about 40 years old, 39, and the largest age group of all the people was the males in the age 40 to 44, and the largest percentage of people who finished were in the 30 to 50 age group. I'm sure if I would ask, a lot of people may say, who usually runs a New York City Marathon or any marathon, you would say, yeah, probably some 20, 30-year-olds tops. But interestingly enough, it's a higher number in the age than you would anticipate. And while most of the people who win the marathon and have the best times, yes, they're in the 20s, but the largest percentage of people who actually finish is the 30 to 50-year-old age group. So this kind of brings up this little topic that I like to talk about as an aside, is about middle age. You know, what middle age kind of keeps changing over the decades, what the definition of it is. And people don't even like that term because it's considered kind of a negative thing, right? You know, oh, he's middle aged now, you know. It's associated with depression, even though most 30 to 40-year-olds, which is probably the early side of middle age these days, they're not depressed. It is also associated with getting sicker or more common health problems, even though most 40 to 50-year-olds are not sick. So what is this term of middle age? It's kind of a frame of reference that relates from when you're a child, where people think of you having limitless potential. You want to be a doctor, I want to be a lawyer, I want to be a fireman. Every day with a new experience, that's what I want to be, that's what I want to be. You're excited, and you always want to try something new. So being a kid, or when you're in the young side, your associated life is with potential. When you get older, you hear things like, she doesn't have the time, he can't do that anymore, I paid my dues, you can't expect that at his age. Those are the things you hear. So you're now associated with limitations rather than potential. So you start to see that middle age is kind of that point in life when you shift from seeing the future in terms of potential to those of limitations. But Bob Hope said it's when your age starts to show around your middle. So let's talk a little bit about the knee. So before we can get into the medicine and the science and the surgeries, we have to know a little bit about basic anatomy. The entire lower extremity, we have the thigh bone, the femur, the shin bone is the tibia, the kneecap is the patella. You have that articular cartilage that was described as that chicken bone, blue shiny stuff at the end of the chicken bone. The ligaments in the knee, the common ones, ACL, PCL, MCL, and LCL. Orthopedics is a very simple medical subdivision, so ACL is anterior, that means there must be a PCL, a posterior one, and MCL is medial, that means there must be an LCL, a lateral. So those are the common stabilizing ligaments in the knee. And then in addition to that, as I mentioned, with the most common surgery is meniscus. The meniscus is a little shock absorber that sits in between the thigh bone and the shin bone. And you can see it depicted here. So this is the femur is the big thigh bone, the kneecap sits right on top, and the tibia, the shin bone, is below it. Medial meniscus, little shock absorber between the bones, lateral meniscus, shock absorber between the bones, and this is in addition to that blue cartilage, which in here is not blue, but kind of this pink or gray or whatever color you think it is, covering the bone. So the ligaments that I mentioned, medial collateral ligament, lateral collateral ligament, and the ACL. The ACL is the one right in the middle, and that's the one that skiers and football players always blow out and injure. Here we are in the blue. So if you take this kind of bird's eye view of the top of the shin bone, you can see the meniscus is this like C-shaped structure. I have to say that slowly. C-shaped structures here and here that, again, act as a little cushion between the two, and that's in addition to this articular cartilage that covers the bone. It helps to distribute load. It does offer some stability or stabilizing component, and it helps protect that cartilage that's there. It is a stress absorber in a sense, but as we age, the ability to absorb and dissipate that stress kind of declines. And that's pretty typical with most structures. As we get older, they dry out a little bit, not as flexible as they once were, so then it can't biomechanically be as effective as it once was. So you can get tears, susceptible to horizontal cleavage tears, which is this kind of, it's just basically dried out, you made one little wrong move, and it tears. Anybody can get meniscus tears. You don't have to be 70, 80, or 90, or you can be 20, you can be 10, you can be 15. But it's not a degenerative tear. You get a tear like that when you're young because it's a trauma. The football player gets tackled awkwardly, his knee gets twisted, and the meniscus tears. So anybody can get a meniscus tear, but the common type of tear is a little different as we get older. It's a degenerative type of tear. And even with repetitive activities, you know, if you're a runner or you go up and down the stairs a lot, you know, this kind of little microscopic insults, one after the other, eventually it just kind of fatigues and rips. So this is just an arthroscopic picture of one. So this is the bottom of the thigh bone. Down here is kind of the top of the shin bone. You see this crab meat structure in here is not supposed to look like that. That's a degenerative meniscus tear. See, it's kind of all different. It's like you took a piece of paper and ripped it up into 1,000 pieces. This is another one, similar. See, the meniscus is supposed to look kind of nice and smooth like this, between the thigh bone and the shin bone. Here is also probably degenerative tear, but this is more like the traumatic one that a young person would get. You can see the status of the knee looks a little bit different. And you get this flap tear, and you can imagine it's just like a little thing flipping around every once in a while. It's like having a pebble in your shoe. You know, sometimes you walk and the pebble doesn't bother you, but sometimes that pebble moves right to underneath the ball of your foot and you go, ow, and your knee even will buckle with the pebble in your shoe. That's the pebble in your knee. So sometimes if it's in the wrong spot, sharp pain, buckle, giving way, stuck sometimes, locking, catching, all those things can happen with meniscus tears. It can happen by itself. It can happen with other injuries. You can have a ligament tear associated with it. You can have a cartilage problem associated with it. When you're younger, it's kind of a bigger insult. You need something major, you know, tackled in football, checked in hockey, car accident, something like that. But as we get older, you can bend over to tie your shoes, and if it's just in the right direction with the right forces, it can tear. So it doesn't have to be much, and it may not even bother you at that time. It may bother you later on. So what would your knee feel like when you have something like this? Well, you may see some swelling. You certainly probably would have pain. And as I mentioned, you can get this locking or catching sensation if that torn flap is in the wrong spot. And with degenerative process down the line, the swelling may happen on and off. You know, if you can have a tear and some arthritis in there, and it'll only bother you like maybe after you've been walking a lot that day. You know, you went to Central Park and you spent a lot of day walking. Then that night you may have a bout of swelling, which gets better after a couple days with some rest, and until you start doing a lot again, then it'll happen over again. The cartilage is another kind of confounding factor in this whole thing, because as I mentioned, the cartilage is there. It covers the bone and protects it and makes it glide one surface over the other very easy. It's made up with a bunch of stuff that you don't have to worry about here, but I list it there because it is made up of some stuff. You know, it's not just rubber that sits there. So there's a lot of things on the market that you may hear about or have even tried yourself or see on one of those airplane when you sit on the airplane, those like American Way magazines or whatever, and they talk about, oh, you can do this to treat your arthritis and your knee will be like you're 18 years old again. Don't buy into that. And the reason you shouldn't buy into that is because they don't really work that well for the reasons that the companies that make them say they work. The cartilage in the joint gets its nutrition simply by diffusion. So, and it also responds to activity. So if you have a knee problem, depending on what it is, as Dr. Van Beek mentioned, like for rotator cuff issues, don't just baby it and put it in the sling. It doesn't like that because it gets even weaker. It needs some kind of stimulation. It needs that diffusion of fluid getting pushed over it and under it and around it to kind of help heal it. Now, I'm not saying you should, no pain, no gain. That doesn't work, because if you have pain when you're doing something, that means something's wrong and you shouldn't be doing it. But if it doesn't hurt, you can do these things and it's beneficial. This is, again, just an actual cadaveric or donor specimen. This is what a knee really looks like, and here is the ACL and the menisci are sitting here, lateral meniscus, medial meniscus. This is an actual knee. Doesn't look too bad, but you can actually see, I don't know how well it projects, it looks great on my screen. The cartilage, you see it's different colors here, right? So, the cartilage should kind of be like nice and thick and robust in one color. Some areas here, this may be actually thinner cartilage where you can kind of see the underlying bone a little bit through it because it's getting so thin. And that's an arthritic process in evolution. And the same thing applies to cartilage as it did to the meniscus. When it doesn't get used, it kind of, what is it, move it or lose it? If you don't use it, it kind of atrophies. It shrinks a little bit, and it's not as active anymore. So you can wind up with problems, softening, fissuring, which is just like a deeper crack, and then this fibrillation type stuff. So this is just an arthroscopic. Again, we try to do most surgeries these days through these little arthroscopic incisions, because you get these actual better view looking at it here, because this is magnified 10 times. And if you don't do it that way, and you do it the kind of old-fashioned way with just a big cut, and you're looking at something that's like really small, and you can barely see it. But by doing it arthroscopically, it's magnified 10 times on a screen, and you actually have much better visibility, and you can do much more with it. So here is an example of this cartilage lesion here. Normal cartilage all around. This is exposed bone underneath the cartilage, which has been kind of torn away for whatever reason. And the most common whatever reason is osteoarthritis, or which is the typical arthritis that most people have experienced in their life. There's also rheumatoid arthritis, which is a completely different animal, and we won't even talk about that. Osteoarthritis affects over 10 million Americans. It's a chronic condition. It's breakdown of this cartilage. It starts out, maybe very, very small, like these two little dots here, and then over time it spreads and gets worse. The way I explain it to patients in the office is it's like I-95. When I-95 is freshly paved, the cars, the trucks, everybody goes over it, no problem, everybody's happy. Over a few winters and a lot of traffic, you get some potholes, right? The potholes start out small, but when the cars and trucks keep going over it, the edges flake and crack, and you get this huge monster pothole, and then it's not fun anymore. So that's what happens. It's a slow kind of process in evolution. And this is an X-ray that shows thigh bone, shin bone. You can't see the kneecap because it's right centered over on top of the thigh bone, but you can see the joint space is almost gone. What I should have put up here is actually like an X-ray that doesn't have arthritis, so you can compare. But you see, it's like these bones are kissing one another. Okay, it's like bone on bone. The cartilage is gone, and it's like two rocks rubbing together. Can you imagine when you take two rocks what that sounds like? And I'm sure people know what that feels like. Again, cartilage injuries can happen by themselves or in conjunction with other things, such as a twisting thing, a powerful impact or force. And then the damage really is graded on minor things to more severe, depending on how big, how deep, and how much of the cartilage is really involved. What will your knee feel like? Well, you'll have some pain, certainly. It may be vague. You may say, it's not really painful. I can live with it, but it aches. I have trouble going up and down the stairs. It bothers me when I squat down and kneel. But it's not debilitating pain. It's not like going to kill you, but it bothers you enough. You can also get some stiffness, as you can imagine, because now that soft, nice, fluid surface of the cartilage is gone, and it's bone on bone, so it doesn't move as well. If pieces flake off and break, you can have loose bodies, meaning the cartilage, like, again, little pebbles kind of floating around in your knee that are sometimes painful if they get into the wrong spot. It's progressive, as I mentioned, because as over time, like the tendons, like everything else, the cartilage loses its ability to stretch, to move out of the way. It gets a little drier, and ultimately you go from this situation to this situation, which you don't need me to explain. This is like knee replacement worthy. Oh, let me go back there. So let's go back. So what are some risk factors for people to get osteoarthritis? Well, age is one of them, but it's not a prerequisite. Not everybody who is over 70, 80, or 90 has arthritis. A lot of people who have arthritis are seemingly in that age group, but that doesn't mean that everybody is. Certainly being overweight, obesity, which is a big problem in this country, because it simply puts more weight and more stress on the joints. Imagine, everybody here seems to be in pretty good shape. Just imagine walking around with a 100-pound pack on your back every day. you're putting more stress on those joints. That cartilage has to do more work. Overuse, repetitive stuff, as I mentioned. Genetics to some degree. Osteoarthritis is genetic, so a lot of it is out of your control and out of my control. Muscle weakness, again, same kind of thing. This is why we mentioned you want to kind of be active and use things, because if the muscles, again in this case we're talking about knee, if the muscles around the knee are weak, that means that the joint is not that well supported, and it can cause some breakdown and problems, and certainly a bunch of other diseases can cause arthritis type things. Lyme disease even has an arthritic component to it because it involves the joints eventually. What will your knee feel like? Pain, stiffness, sometimes that grating, like again, use the rock on rock analogy. Pain with stairs up and down. Some people say, oh, it hurts more when I go up the stairs, it doesn't bother me down. Some people say it bothers me down, it doesn't bother me up. Bottom line, it's a problem with stairs. Getting in and out of the car, you know, because the way we often do it is kind of a sideways twisting motion, you know, and when we have problems, you find that people actually are much more systematic with how they get in and out of the car. They are sitting here behind the wheel, they'll turn their feet, the door's open, and then get up that way, and even getting in, you'll sit down and then swing. You know, when you're 16, you know, you bounce through the window. So, like the Dukes of Hazzard used to do it, right? So, now we'll just move on to this anterior cruciate ligament. So the ACL is this anterior cruciate ligament, is one of the more common ligament stabilizers. It prevents the shin bone from sliding too far forward on the thigh bone. Go to next. It also does some kind of rotation control of the thigh bone on the tibia and the shin bone, but mainly it kind of prevents the shin bone from sliding too far forward. I'm going to try and show this for 1 second because I think it's worth it. Anybody know who Willis McGahee was, or is? I shouldn't say was. He's still alive. So. This is a real serious hit. Will Allen put on Willis McGahee. Hit him low, and they're looking at his left leg right now. So they're going to show the replay of how this happens. Will Allen with 2 big shots, one on Winslow, and then this one. Oh my God! And you see, this is basically like a knee dislocation in a sense. All right, we'll get out of there. And I'm going to pull something else up later. Minimize that.
Why do you make all that money these football players?
Well, that's a good point. Okay, so he, by the way, not only, oh my God. You know, this is what happens. Stop. How painful. All right. From current slide. So he tore his ACL among other ligaments in his knee, but certainly an ACL tear alone is very common. It's actually much more common in females on a percentage basis, and there's a bunch of reasons why. Some of them have to deal with the kind of body design. Most women tend to be wider at the hips for childbearing purposes, so in effect you wind up with kind of this knock-knee type of a picture, while as males are kind of broader up here, so their legs are straight. So the women have this, and that kind of angle at the knee with the right or wrong force can subject that ACL to tear. Another theory was the effect of certain hormones, such as estrogen, during the ovulation times, the menstrual cycle. Those times of the month, those hormones are very high in the blood level, and their effect on the ligament directly actually makes the ligaments looser. Again, it has to do obviously with, you know, you can imagine also during childbirth, you need the ligaments to be loose. So I don't feel that pain. So, but the theory that actually has gotten the most credibility now is this neuromuscular control patterns. And what that means is, if you took a pro football player, actually let's do this, a pro basketball player male and a pro basketball player female, and had them run across the stage, jump and dunk the ball and land, they would do it, and so would the female basketball player. but the way they would do it would be a little bit differently. The muscles fire in a different order, in a different intensity, so they run, they jump, and they land differently. And that whole chain of events puts their knee at risk in a female because of the knock knee thing, and then when they land, they tend to land like this, whereas male athletes will tend to land like this, straight, and they're more subject to tear. Now, certainly in the country, there are more people who have ACL tears that are male because there's more male athletes playing in sports and from Pop Warner football all the way on up. But by a percentage basis, it's much more common in females to get an ACL tear. 50% of them will have an associated meniscus tear, which we kind of already went to. When it happens at the time of the ACL tear at the same time, and it's usually the lateral one that tears, if you don't tear them at the time of the ACL, you will likely tear the medial one later on, because now that ACL is not there doing its thing, so the bones can move a little bit more than they're supposed to, and that medial meniscus becomes under tension. The ACL is important in certain athletes, but not all of them. Running and cutting, pivoting sports. I shouldn't even put running in here, but cutting and pivoting sports, football, soccer, anything that requires a quick change of direction, you need your ACL for. But if you're a marathon runner, you can live without your ACL. You can run straight like this for hours. You don't necessarily need your ACL for that. As I mentioned, ACL deficient knee is associated with meniscus tears and some arthritis to some degree, but not because your ACL isn't there anymore. In order for somebody to get an ACL tear, what has to happen is this kind of motion, as I mentioned before. It's kind of a twist and a bend. So the bone kind of smacks against one another. And where that bone smacks, the cartilage gets kind of sandwiched in between. And at the time of that ACL injury, that smack to the cartilage damages it a little bit. Not completely, but it like stuns it. And then over time, it kind of breaks up a little bit. And it breaks down, and it breaks down. It's like that pothole, very early, and then it slowly develops this pothole, and you can get arthritis. We used to think that, oh, this person has an ACL tear, he better get it surgery because then if he doesn't get it, his knee's going to move around too much, and he's going to get arthritis. That made sense in that logic at the time. But what we found was that patients who had ACL surgery wound up getting arthritis anyway. So that's why we've now figured out, because the arthritis happens because of the smack at the time of the ACL. So fixing the ACL or not doesn't change that. You can't reverse that. And interestingly enough, there are some very recent papers that show that patients who have ACL surgery get more arthritis than the people who don't. And there are some reasons for that. The way the surgery was done, sometimes we made the knee too tight with too much force across that cartilage, so they got too much breakdown, and they get arthritis for that reason as well. So there's a lot of things. ACL is probably one of the most commonly researched and talked about things in all of medicine. 65 to 75,000 surgeries are done every year with the thought to restore stability and get patients back to their activity level with a pretty high success rate. But I will also tell you this, it's an overdone operation. Not everybody who comes through your door with an ACL tear needs to have surgery because they're not necessarily unstable. And if they come because their friend or they did a Google search saying, I better do this or I won't get arthritis, we'll often have to educate them a little bit and say, you may still get arthritis even if we do this, for the reasons that I just mentioned. I will tell you also, I'm the president and the victim of the club. I tore my ACL and MCL about 6-7 years ago playing basketball, and I came down, landed awkwardly like that, felt the pop, the whole thing. I never had surgery on it, and I still play basketball and I still play ice hockey just as lousy as I've always played. It hasn't changed anything. So not everybody needs the surgery. People who do need the surgery are people who want to return to playing college football or kind of that level, or even not even the collegiate or professional athlete. If, for example, if I wanted to go back to playing hockey, but I was having trouble playing hockey with with my unstable knee or knee buckling, then I would say, you know what, maybe I should have the surgery if I'm not willing to give that activity up. But people who are level 3 here with light manual work, non-cutting sports, like I mentioned, running straight ahead, sedentary activity, you don't necessarily have to have the surgery. Not a real benefit. Usually, if you're younger, 17, 18, 19, 20, when this happens commonly, we'll offer them surgery even though they're not a professional football player yet, but you never know where somebody wants to go with their lives, so you'll offer them surgery. And then, as I mentioned, people who have what we call functionally unstable knees. So you've torn your ACL, you've gone through a few weeks of rehab, and the swelling has gone down, the motion has gone back, but when you walk up and down the stairs, your knee gives out. That's just not safe, right? You're carrying a bag of groceries, you're going to fall down the stairs. That's just not a safe situation. So those people should have surgery. But if they're not what we call functionally unstable, they don't have to have it. It's not an automatic, although it does help with the mortgage payments. So, let me do this one back. Sensitive. So what do we see on physical exam for a lot of these things? For the ACL, you'll have a swollen knee, which is what a fusion means. You want to look at what their overall alignment is. As I mentioned, sometimes patients come in and they're bow-legged to start with or knock-kneed to start with. All these things kind of have a bearing on whether doing ACL surgery is even going to be successful. You could do the surgery easily enough, but if a patient has significant bow-legged deformity or flat feet and some other things, it's going to fail. The ligament's just going to tear 6 months later. So you have to look at the whole patient, before you just jump into the operating room. Range of motion may be diminished. It could be diminished because of swelling. It could be diminished because there's a displaced meniscus tear, again, blocking the motion. Normal flexion is to about 140 degrees. That's pretty far. Some people can only get to 90 or so. You need about 115, 110, 115 to kind of do most activities of daily living. And the reason they come up with 115 is because that's what you need when you're sitting on a toilet. It's not a regular chair, right? It's a little lower than that. So if you're down this far, you're never going to get back up again. So you need that kind of 115 degree of motion to be able to do most activities. You don't need 140. We'll do an examination to look at it. We'll palpate it to see if there's tenderness, to look for fracture. We'll do a ligament exam to assess for the integrity of the ligaments. But again, in the beginning, when an injury happens, it's hard to do an exam on a person because it's swollen, it's painful. Anything you do, you just walk up to it and they say, ow. So you have to, you just wait, let it relax, come back a week later, have the patient come back a week later and reassess it. Now the swelling is down, they're not as apprehensive anymore, and you can do a better exam. A Lockman test for the ACL is just this, basically, remember I said that the ACL is supposed to prevent the shin bone from moving too far forward relative to the thigh bone, which is here. So here's thigh bone, the patient's head is to the left, foot is to the right, this is the kneecap. Just grab the thigh, grab the shin, and pull the shin forward. And if it moves more than it should, probably is an ACL tear. But if it stops, that means the ACL is getting tight and doing its job. There's a whole bunch of things to compare it to the other side, because some people just have like general lax ligaments. Everybody knows who Abraham Lincoln was, right? Anybody know what disease he was thought to have had? It's a thing called Marfan syndrome, which is why he was so tall. And he had these really long, spindly, spider-like fingers. And patients who have Marfan syndrome have very lax ligaments, very loose ligaments. They're almost double jointed a lot of times. So you might want to think twice about doing ACL surgery in Lincoln. Not that because his insurance plan was lousy, but because it's going to fail. It's going to fail because all the ligaments are loose. We're not going to do that one. This is another test. This is another test. Same thing, and you can kind of see it here. This is just the same thing with the knee bent a little bit more. Thigh bone here again, head to the left, foot down to the bottom right, kneecaps kind of up here. And you can get this sense, if you follow the anterior skin line here, all of a sudden it kind of goes out a little further. And that's because they're pulling on the tibia, pulling on the shin bone. like this, and it's moving way too much. It should kind of stop like at this level. Everybody get what I'm trying to say here? Okay, it's hard to, I know I understand it. So it's getting warm in here. I keep it short. Knee issues, very common. You can have these things even after minor trauma, like I said, bending over to tie your shoes, a misstep on the curb. There's a lot of treatment options, but the treatment options are patient dependent, not injury dependent. Just because there's an ACL tear doesn't mean it's surgery. Just because there's a meniscus tear doesn't mean it's surgery. Just because there's arthritis doesn't mean it's surgery. You have to think about the patient as a whole. What are their expectations? What are their activities like? What do they want out of this whole experience? And what we certainly know is that exercise and activity are extremely beneficial for obviously many processes across the board. Now, I'm going to, one thing here, so let's see this one, see if we can get it to work. Anybody know who Julie Moss is? I'm going to pull it up in a second. This is one of my favorite quotes because this is what I live by now. Let's see. Hang on. Just bear with me. This is about a 3-minute video. Does everybody have 3 minutes? Hang on. Okay, so Julie Moss was actually a graduate student. Where is she? I'm going to pull this up right here. And stop. So she was a graduate student, and she went to, in 1982, she went to Hawaii to do the first Ironman triathlon. Everybody knows what the Ironman triathlon is? You know, it's a 2.5-mile swim. What was it, the bike? 110-mile bike ride, followed by a marathon, 26-mile run. So she really didn't have much in the way of training because she was only going there to do a thesis on this new craze called triathlons that was just starting up, and she entered it. And interestingly enough, after the swim and after the bike and after a large portion of the run, she was in first place of the women. And this is what the end of it was. I don't know if you can hear this. Can you hear it?
Moss came to the Ironman as a college student, just trying to get a degree. No one could have imagined she'd find herself in the lead so late in the race.
This was on national television.
That was Kathleen McCartney, who was in second place in the women's event, nearly 20 minutes behind Julie when the marathon began. As night fell in Kailua Kona, an exhausted Julie Moss was clearly in trouble. Quickly back on her feet, but again her body said no more. Moss would walk methodically down a Leahy Drive, now just a few hundred yards from the finish.
A few hundred yards from the finish here.
Just 30 yards from victory. Moss fights against a
30 yards left.
ABC's cameras captured this drama. As Moss struggled trying to balance as if on an earthquake, her worst fears
Watch
were
what happens
realized as
right
Kathleen
here.
McCartney
involved on
One of
the
the most
needs to
memorable
get
moments
across.
for
I
history.
mean, you can't see this well on the video, but I mean, she had lost control of the valves and
Was
everything.
mesmerized by
Short
Ross's
and
courage
soiled,
and
all this stuff, but
determination.
it's a, you see it's from videos for motivation, so I certainly wouldn't recommend this kind of a thing for anybody,
Showed us the
but
brave day forward. The Ironman
you know,
was epic.
the reason I show it is, here quickly, is I think it's great for people to get involved in an exercise program. Now, this is obviously very extreme, but you want to do it smart. You want to do it, you know, under the auspices of a physician, especially if you have any kind of medical condition or anything at all. Do things slowly and gradually. Don't just fly to Hawaii and do the Ironman. Okay? And with that, I will close. Thank you very much. Any questions? Yes?
Why is it, I've had a knee replacement, not because I'm old,
Uh-huh.
because I had a bad bike crash when I was a young child.
Correct?
How come some people, if you don't have a propensity to get scar tissue, why do you get scar tissue in your recovery?
Well, certainly some of it, any surgery, any trauma, let's go back, any trauma can result in scar tissue from the trauma. Okay? And surgery you can consider as a type of trauma to the body part that's being operated on. You know, you're making a cut, especially with something like a knee replacement, you're making a cut, you're going through the skin, you're going through the muscle, you're going through the fat, you're going through the, you know, getting down to the bone, making these big cuts, taking the cartilage out, putting a metal cap on. It's a big deal. You know it. And the body is trying to heal that stuff, and the body heals things with scar tissue. When you cut your skin, it deals with scar tissue. Some people, if are kind of predisposed to develop scar tissue more than others. Sometimes it has to do even with rehab. If you're not aggressive enough with the rehab because it hurts too much, you know, so you kind of leave it